This video provides some background information about the Cheetah NICOM monitor, why cardiac output monitoring is important, and how the NICOM monitor compares to other available cardiac output monitors. In the 1960s, it became clear that patients who underwent major surgery and did not receive adequate perioperative fluids did not do well. Invasive catheters were increasingly used in the 70s and 90s for sick patients undergoing major surgery, and this was associated with more aggressive fluid therapy. By 2000, it was clear that patients who received too much fluid were not doing well, and the concept of goal-directed fluid therapy was born. By 2011, new minimally invasive cardiac output monitors combined with enhanced recovery protocols for goal-directed fluid therapy were demonstrating a decrease in both morbidity, length of stay, and mortality following major surgery. Our current perioperative monitors include non-invasive monitors, minimally invasive monitors, such as an arterial line, central line, or echo, and more invasive monitors such as a pulmonary artery catheter. We now have a plethora of both non-invasive and minimally invasive cardiac output monitoring devices. These include, but are not limited to, the esophageal Doppler CardioQ monitor and pulse contour monitors such as the Edwards FlowTrack and LIDCO monitor. The focus of this talk will be mainly about the Cheetah NICOM non-invasive cardiac output monitor and its use in the perioperative period. With inadequate fluid administration in the perioperative period, the risk of renal failure, sepsis, and multi-organ failure increases. With excessive fluid administration, a spectrum of risks are introduced, with pulmonary edema and congestive heart failure at the far end of the spectrum. Other more subtle features of excessive fluid administration include postoperative nausea, wound edema, ileus, and cardiopulmonary complications. So why is hemodynamic optimization important? Perhaps a better term than goal-directed therapy is the goal of optimizing hemodynamics and organ tissue oxygenation, and there is a wealth of literature supporting the importance of this to reduce perioperative complications, morbidity, and mortality. Cardiac output is a product of the heart rate and stroke volume. The heart rate and blood pressure are commonly monitored as indicators of patient well-being, but may not reveal inadequacies in tissue perfusion and oxygenation. New minimally invasive and non-invasive monitors used to assess stroke volume and hence cardiac output are able to predict whether or not a patient may benefit from additional fluid or vasoactive medications. So why not just give fluids and see if the patient improves? In a review of critically ill ICU patients that were hypotensive, only 50% were found to benefit from a fluid administration with an improvement in cardiac output. The amount of fluids administered to critically ill patients correlates with mortality. Reliance on CVP measurements in these patients has also been shown to be unreliable and should not be used to make clinical decisions regarding fluid management. So morbidity and mortality correlate with both perioperative fluid excess and deficiencies, and predicting whether additional fluids are indicated based on traditional monitors is unreliable. Hamilton reviewed the perioperative mortality of patients who had cardiac output monitoring to permit goal-directed therapy and showed that the pooled data of patients where goal-directed therapy was used had better survival rates. Hamilton also showed that perioperative complications were significantly reduced when a cardiac output monitor was used for goal-directed therapy. Shoemaker demonstrated that the longer a patient was in a prolonged state of shock with inadequate tissue oxygenation, the poorer the outcome. New minimally invasive cardiac output monitors now offer the ability to measure cardiac output and oxygen delivery to identify and correct inadequacies in tissue oxygenation. A systematic review of over 40 years of experience with the pulmonary artery catheter showed a reduction in morbidity and mortality in high-risk patients undergoing major surgery. It is also clear that similar reductions in complications can be obtained with minimally invasive monitors such as the FlowTrack, LIDCO, and esophageal Doppler. A plethora of studies with goal-directed therapy using an esophageal Doppler monitor have validated its utility. The UK National Institute of Clinical Excellence supports the use of an esophageal Doppler monitor for patients undergoing high-risk surgery. A recent comparison of the Cheetah NICOM monitor has shown that it is as good or better than an esophageal Doppler monitor. Duke University has been using goal-directed fluid therapy and enhanced recovery protocols for a number of years for patients undergoing colorectal surgery. Goal-directed fluid management is just one part of the bigger enhanced recovery protocol. The Duke protocol addresses fluid management issues in the preoperative, intraoperative, and postoperative period with intraoperative cardiac output monitoring to direct fluid management. With this protocol, they have been able to significantly reduce length of stay for both laparoscopic and open colorectal procedures, as well as significant reductions in wound and urinary tract infection rates. So why choose the Cheetah NICOM monitor? This table summarizes the ideal requirements of a cardiac output monitor. The monitor should be minimally or completely non-invasive. It should be able to obtain measurements irrespective of whether the patient is breathing spontaneously or on a ventilator, or whether the patient is awake or under a general anesthetic. There should be minimal interference from movement, and it should be adaptable to a wide range of ages and weights. It should offer continuous trends. It would be nice if it could also provide calculations of thoracic fluid content, and obviously it has to be reliable, precise, and fast. Finally, there should be minimal training required to use the monitor. The Cheetah NICOM monitor is the only current FDA-approved non-invasive cardiac output monitor and the only monitor that meets all the requirements of an ideal cardiac output monitor. As the Cheetah NICOM monitor is completely non-invasive, there is no time limit for monitoring with it. It can be used in the preoperative period prior to surgery to assess volume status and baseline cardiac output, and can be used both in the OR and postoperatively. It can be used with spontaneous or controlled ventilation, and its flexible sensor placement allows it to adapt to different patient positions.